So today, actually, we have co-speakers. Our speakers today are Erin Rewerts, and Erin is Assistant Director, Case Management Supervisor at Story County Community Services in Ames. And also, we have Christy Krause, who currently is the Director of Behavioral Health Services at Mary Greeley Medical Center. Topic today, I think, is of particular interest to primary care providers out there. We're going to be discussing mental health services in Story County, and please join me in welcoming Christy and Erin.
Well, we want to thank everyone for allowing Erin and I to share part of your day. Obviously a topic that's very near and dear to our hearts, something we work with day in and day out. We would acknowledge that this system is complex, very complex, the mental health system. Access is difficult, and payment for services is also very difficult. So we're hoping today for you to come away with a few things, to understand perhaps some of the payment options for mental health services in our community, have an increased awareness of some referral options that you folks can access and direct those clients that you serve for services. And also, there are a lot of changes coming down the pike here related to mental health services. These changes relate to local system changes as well as those related to some recent legislative action on behalf of the legislature here in the state of Iowa, and as well as federal changes. So we'll give you a little glimpse of those things. Kind of unusual to start a presentation about an area of healthcare around payment options, but the unfortunate thing about mental health is directing folks for care is very dependent upon the payment options that are available. And so that's why we're starting today's presentation with this discussion about payment sources. So the payment source, as I said, often does determine access to care. Typically, private practitioners will serve the traditional commercially insured folks, okay? So a lot of our private providers serve the Blue Cross, United Healthcare, etc. The community mental health centers, which here in Story County is Eyerly Ball, and other agencies that receive government funding, and those would be places like the Richmond Center, Youth and Shelter Services, Lutheran Social Services in this community. They typically serve those folks who are funded by Medicare, Medicaid, self-pay clients, as well as county funded. I thought it might be of interest for you to see the bottom of this slide, the payment breakdown for folks who present here to the hospital for mental health services. So we have about 33% that are served by traditional commercial insurance. About another 30% are Medicare, and that's both those folks who are traditional Medicare services, the elderly, as well as those folks who might be disabled or are on SSI. Then we have about 15% are Medicaid, just over 4% for self-pay, and just 0.3% for federal programs. This might be your military folks that are under the Champus coverage. And then about 16.3% of folks are county funded. So a great reason why Erin is with us today, because the county funding system is very difficult to understand and is complicated as well. So these are the generalized service providers in the Story County area. Here at Mary Greeley Medical Center, we provide inpatient care as well as crisis-related services. We also have a very small 6-bed transitional living program on the campus. It's often referred to as the little white house behind the parking ramp. So we do have a transitional care program where we transition folks from the hospital back to the community. As I mentioned, our community mental health center here in Story County is Eyerly Ball. Other community providers are the Richmond Center, Youth and Shelter Services, Lutheran Social Services, and the primary substance abuse provider in the community is Community and Family Resources, often referred to as CFR. You may hear that term used. And then there's a whole host of private physician clinics and counseling clinics that are available in Story County. You might have picked up at the door when you came in, Erin and I have tried to put together a resource list of providers in the community. I apologize if there might be a resource on that you're aware of that is not on this list, but we did the best that we could in pulling together a list that might direct you in where you could direct some of those people that you serve for services. So we wanted to make sure that you had that available to you. So I just wanted to speak for a moment about the evolution of the local community mental health center. There was a lot about this in the media, particularly a year ago, last 2 years. And basically how the community mental health center distinction works is the county gives that distinction for the community mental health center. And historically that distinction was the Richmond Center, was our local community mental health center. There were concerns that arose related to sustainability and provision of services related to that particular provider. The county made a decision to put out a request for proposal for the mental health center activities, and after that proposal, that award was given to Irely Ball. And so they have been providing community mental health services here in the Ames area for approximately 1 year. I'm going to turn it over to Erin here.
I think now it's my turn. The reason I'm here, as Christy said, is to kind of explain the county funding portion of it. I'm going to skim the surface, and so we left some time at the end for questions and that kind of thing if you've got that. But for the county, as far as eligibility criteria, we look at income and resources, diagnostic criteria. So we serve folks that have chronic mental illness, developmental disabilities, or intellectual disabilities. And then residency. This is also something that changed July 1st. There used to be an antiquated system that we had about called legal settlement. And now it's changed to, where you live is where, who's going to be responsible for paying for your services and the services that you're going to get. There are a few exceptions, and just a couple examples. College students who don't intend to live here and reside here besides going to college are excluded. People who are in jail, things like that. But if you are a homeless person and you can say, you're staying at the shelter or you're, staying on a park bench or something like that, you're considered a resident, and Story County will find services for you. And then there's an application process as well. And kind of what Christy was talking about when we were talking about the mental health centers, part of that is a contract. And Story County is now regionalizing with other counties, and I have that in a couple slides here where I'll explain a little bit further. But those contracts with providers, for example, Irely Ball, need to be negotiated and for rates and what the county will pay. And our new region name is right here, and I don't think I put it anywhere else, so I'll just kind of highlight it, but it's Central Iowa Community Services. And then when a person is eligible and the county is going to pay for services, they will issue what we call an NOD, a Notice of Decision, to authorize the services and what will be paid for. So, mental health redesign legislation. This was also in the papers a lot and things like that. But basically, Story County is going to regionalize with 8 other counties that are listed there. And one of their first things that they needed to do was form a 28E agreement. Story County has chosen to complete that and get this region formed by July 1st of this year, was our goal. The legislation does not require that to be done until July 1st of 2014. There will be a regional board of directors, and I've got it listed here who will be on that board. So there'll be one board of supervisor member from each county, And then there will also be a provider representative. So that would be your community life program or Early Ball, you know, a provider of that sort. And then one consumer or family member representative as well. So Central Iowa Community Services also will need to choose a regional administrator, a regional advisory committee, which we just talked about, and also a fiscal agent. So one of the member counties will assume that responsibility. The intent is to have a regional board in place and to be pooling the funds from all of these counties effective July 1st. I already talked about that. So part of this legislation involves core services. These are required by Senate File 2315. And the intent is to form a formation of continuum of care to improve quality and cost effectiveness. Core service domains include treatment, crisis response, supported community living, supported employment, recovery services, and service coordination. Now, there are also Core Plus services that regions are going to be expected to have as well as funds are available. And those are listed here as well. Prescription assistance programs are another thing that we have here in Story County. And how it kind of works is there's a limited list of medications for physical and mental health. And this would be a way for someone who didn't have any type of way to pay for their medications. No insurance, no Medicaid, and things of that nature. And as we all know, medications are pretty expensive and that can be problematic for folks. So under this program, you can get a 90-day script that costs $3. Most of our local pharmacies here participate, and there's actually a hardship form as well. So if you can't afford the if the consumer can't afford the $3, then they can fill out this form, and meds are mailed to you. Early Ball, our mental health center, has someone that can assist people with getting hooked up with these programs, because I don't think that's probably a really easy thing for people to do either. So that is where they can go to get that. And a person can get Story County funding if they're eligible for their medications for up to 6 months. And I think that's you.
Just a few thoughts about the regionalization process. And people often ask me here at the hospital what I feel about that, what are my thoughts on the topic. For a long time here at the hospital, that has been a source of frustration for us in treating folks. 99 counties, and I can say for our mental health unit, we take clients from all 99 counties. We have folks coming here every day from all over the state of Iowa to seek care because there are access issues in their region or their community. And so it was very difficult for us as a provider to deal with the processes, the contracts, the resources related to 99 counties. And so it was really fortunate for us, the regionalization, because what's happening now is counties are forming these regions, and for the most part you're seeing 3 and up to as many as 20 some counties forming now into regions. The only standalone county at this point that I believe that DHS is going to approve is Polk County. And they are large enough that they probably can sustain a single county system. But at this point, we here at Mary Greeley have signed letters of intent for our inpatient program to serve 4 regions. And that's primarily the central counties, that Story County included, and those counties around us, as well as a significant number of counties to our south who really do not have a lot of services, excluding Polk County. So the ideal of the regional relationships is to start looking at gaps in service, improving continuums of care, eliminating duplication, eliminating a lot of that confusion around every county having their own systems in place. So I'm really looking forward to working within the regional system, and I think it offers us a lot of hope into improving care. So I did want to talk about a new program that we're initiating here at Mary Greeley, and it's called the Connections Program. It is in affiliation with the local mental health center, Irely Ball. And one of the challenges we have is we can put a lot of resources and effort into getting someone better and getting them well, or at least on their way to improve mental health. And then we discharge them to the community, and for whatever reason, and there are many, they decompensate. And they end up back in our emergency room in a few weeks, in a few months, and we start all over again. And so what this program will do is one of the staff from Irely Ball will actually be coming to the medical center and working with clients from Story and Boone County that are on our unit and working to transition them back to community-based services. So, and we're talking about working very closely, making sure appointments are made, picking them up, making sure that they have picked up their prescriptions, helping them to initiate their medications and medication management, picking them up, making sure that they're getting to their outpatient appointments. So we're hoping that this type of program is going to sustain folks for a longer period of time and make sure that they're really getting a longer term sustainability so that they're going to be more successful out into the community. So that's our new program that we're getting started here.
Okay, so the next thing I'm going to talk about is integrated health homes. I think that everybody here has probably heard this term for a couple reasons. The chronic conditions health homes are a primary care focus, and I believe they started in the state of Iowa about a year ago. The one that kind of hit the ground running July 1st was integrated health homes to serve adults with chronic mental illness and then also children with serious emotional disturbances. And this approach is a coordination of different entities, which I'm going to explain a little later, but in a holistic manner involving a whole team of people kind of surrounding this one person and giving them a continuity of care. Chronic conditions for the primary care focused homes are listed here: hypertension, overweight, heart disease. So primarily your chronic physical conditions, and then also mental health. So a person to be eligible for one of these health homes would need to have at least 2 chronic conditions or 1 chronic condition and at a risk for a second. The integrated health homes cover these types of diagnoses. I don't believe this is a comprehensive list, but this is the one that Magellan has circulated to folks. But psychotic disorders, schizophrenia, major depression, delusional disorder, and then here's the children with the serious emotional disturbance. And then consideration is also given to individuals with a GAF score of 50 or less. And who can be a health home? There's a little bit of control over this as well, but here's a physician clinic, a community mental health center, federally qualified health center, or a rural health center. And one of the qualifications for this is that Magellan has to agree to fund you and contract with you and that kind of thing. So there is a lot of movement around the state of companies that are trying to decide if they want to be health homes or not. In Polk County right now, they started July 1, and a couple examples of their health homes for people with chronic mental illness are Irely Ball and then also Broadlawns. I kind of said that already. And so Magellan piloted a program for an entire year. Back in 2011, they started actually in 5 counties in Iowa to see if this was, it's a totally new structure for people and to just see if this is the way that the state wanted to go. And that's what they chose. I wanted to talk about those just a little further. So part of the components of the health home is that a person will have, they can have their services anywhere. So they can have a psychiatrist, a therapist, and a primary care doctor, and all those in different agencies, if that's how it works for them. And then what they're going to have when they get assigned a health home is a care coordinator. And that person is going to be in charge of making sure that the person's getting to their appointments and, they're focusing on their health and that kind of thing. And the other component is a peer support specialist or a family support specialist. And those are folks with lived experience with chronic mental illness to work with those folks as kind of a support and to be able to provide some direct support type services to those folks. So that's kind of very much in a nutshell, but I'm also not an expert on that topic. So, Christy?
Erin, do you know the activity, the health home activity that's going on specifically here in the Ames community?
The way that they're phasing in the program for health homes is that they have it in 3 phases. So this first phase started July 1st, and that's, I won't get all the 5 counties right, but Polk County, Woodbury, Lynn County, I think, and a couple others. And then phase 2 is slated, I think, to begin. It was January. I think they've moved that to March, and that will encompass several other counties. And then Story County is actually in phase 3, which is supposed to start July 1st of 2014. So there's a bit of a transition type thing because a lot of the folks that qualify for these health homes have case management, and they will eventually be transferred to these care coordinators in these health homes. So there will be some of that going on here.
I have not heard of a lot of significant activity. I mean, lots of things are starting to happen, but particularly in Story County. I know that Broadlawns is gearing up because they are the primary health home in Polk County, and last I knew, they are going to start with 3,000 people as part of their health home, and are putting together those services for all of those folks. So I'm sure we're going to really learn from the primary pilot areas as to how that is all happening, and I know Irely Ball is intimately involved with that process as well. So them also being here in Ames is really going to help us with that transition. So closing thoughts, we know this system to be very complex. Resources are often dependent upon how they're paid for. We have a lot of changes that are going to take place over the next probably 1 to 5 years here, and will directly impact us in Story County. Provided you the list of resources, tried to separate that by frequently we get calls about a psychiatrist, or we need to get someone into a prescribing provider. And those folks are limited here in Ames, so I tried to provide you the list of prescribing providers here in Ames. And then also provided you on that list other folks, counseling agencies, therapy agencies, and so forth on the list that I gave you. Do any of you have any questions that Erin and I can try to answer? Dr. Dodd.
First one is, what is the cost for a psychiatric patient at this hospital? And second, do you think it would be wise to start psychotic patients on injectable medicines in the hospital, since the most common cause of readmission is that they have stopped their medication?
Good questions, Dr. Dodd. I needed Dr. Trahan here in this speak to us. But
I can answer that one.
but for the most part, those folks that we know where compliance is an issue, we are moving them toward injectable medications. And a lot of times we put that in the control of someone else who's going to be in the home and making sure, or link them up to a provider such as Irely Ball to make sure that those medications are administered. One unfortunate fact with some of those injectables, they are very, very expensive. And so we're working on some strategies to bridge that with the pharmaceutical companies, since they are so expensive but very effective. Obviously, the inpatient per day cost is the highest cost that we endure in the entire system, well over $1,000 a day. And unfortunately, that is where most people are landing. They're either landing in the emergency department or they're landing on inpatient mental health units. And you will often hear people say, we don't have enough inpatient beds. We need more inpatient mental health beds. This is my opinion, and my opinion only, but based on my experience, we have a lot of folks in inpatient beds who are stuck and we're not able to move them into appropriate levels of care because those levels of care are not available. So with the hope of regionalization, those continuums of care will be developed so that we are able to move those people more appropriately throughout the system into a lower level and much lower cost level of care. For example, we have recently had a quite elderly patient on our unit for 7 weeks approximately. After 2 weeks, she was stabilized, ready to move to a lower level of care. It took us 5 weeks to get that patient through the system and discharged to an appropriate level of care. Many of you may know that the mental health institutes, the MHIs here in Iowa, have significantly reduced the number of beds that they have. That used to be a level of care that we depended upon for what we call subacute care. And what that is when someone, we get them on their way, medications initiated, seems to be the appropriate medication regimen. They're just going to need a long time to stabilize. They may need to take 2 weeks, 3 weeks, 4 weeks to stabilize. And we used to depend on those state hospitals to do that care stabilization. So after we got them well on their way, we would transfer them to a state hospital. That isn't an easy thing to do today. Those beds are limited. They're getting very particular about the patients they will accept. So those longer-term subacute folks are also backing up into inpatient beds. We see nursing homes, long-term care facilities frustrated with clients with behavioral issues, so they bring them to the ER and say, you know what, we don't want them back. So they end up in our unit. So that's, in particular, some challenges that we face on the inpatient unit, is moving those people to a lower level of care. Dr. Kitchell?
Just had a question about the patients that are going into these health homes. Are these the Medicaid and the county pay patients? I presume we're not talking about getting Medicare or commercial insurance patients into health homes.
To my knowledge, I believe it's Medicaid.
Because I presume this is a Magellan type of directed program.
Correct.
So the question is, obviously, some of these mental health providers will become these health homes, but who is going to be monitoring them to make sure that they're doing the care coordination that these patients need? I found it interesting that Irely Ball, you told us, was actually driving these patients to their appointments so that they would show. I know a no-show rate is really a problem for most mental health providers, but Medicaid has some medical homes or health homes for our primary care physicians, and we've had only a limited experience with our primary care physicians. We could hear from some of them here today, but the burden of the paperwork to do this care coordination was really quite a bit of burden for our primary care physicians. And so the program hasn't really gotten off like it was hopefully supposed to. And this is to coordinate diabetes, heart failure, etc. So it's easy to say let's get these people so that they get their care coordinated, but actually doing it and measuring it is again a challenge. The problem is somebody's got to take responsibility, and if the patients don't take responsibility, who's going to take responsibility?
I don't see mental health as any different than any of those other chronic conditions, and the required paperwork and the so you know that would be an unfortunate outcome for the system. I'm hoping that in these pilots that they're going to identify some of these barriers and burdens and say, you know what, we can't do it for that. And the worst case scenario for these health homes is going to be that these people are hospitalized. So that's why they're going to be putting a lot of energy and resources into making sure they're successful outside of the hospital. So I'm hopeful. Anything that can change for us is going to be positive. I mean, this system has relied on the emergency room and the inpatient hospitalization for a very long time. So any movement we can get in expanding that community-based mental health system is going to be a success.
To your point, I recently found out about something the state of Iowa is doing that seems somewhat uniquely stupid, so I would appeal to everybody to talk to their state rep, as I have, and nag politicians. It turns out I'm seeing a psychiatrist, as many of you know. My fiance is a shrink, now inpatient psychiatry director at the VA down in Des Moines, and she tells me that up in Minnesota, when you need a judge to deprive somebody of their civil liberties and put them in an institution, that makes perfect sense to me. But in Iowa, you need a judge to spring them. So, Bob's suicidal and a threat to himself or somebody else, and they have to put him in an inpatient facility. But to get him out, I gather, in the state of Iowa, you need a judge to sign off on his discharge. That's not true in Minnesota. The judge is going to defer to the psychiatrist. They're not going to say, no, I think he needs a few more days. The judge is going to presumably, and always has, Lori says, rubber stamped, her recommendation. But that's a little quirk about Iowa. What that means, if you're from some county that only staffs its magistrate on Tuesdays and Thursdays, if you become no longer a threat to yourself or others on Friday, you're just out of luck until the judge is back there to say, yep, time to go home. So I just thought I'd throw that out there.
Yeah. You didn't give me enough time to talk about the court systems today because that would be a whole nother topic. But absolutely, that's another thing that gets folks caught up in the inpatient beds that we have. I will tell you, we have a very close working relationship with the courts in Story County as well as this judicial district. We are very fortunate, but that's a relationship that we've spent a lot of time working on. We used to meet monthly with these folks, and now we're down to quarterly, but working as a team, the courts as well as mental health providers, correction system to pull down barriers and remove barriers to getting folks what they need. And so it's very easy for me to pick up the phone or fire off an email to one of our magistrates and say, hey, this is what happened at the hospital this week, and this was the consequence, and work with them. Now, once you get outside of our judicial district, it gets a lot more complicated. And we literally have folks ordered to the hospital who do not belong here under court order, and they cannot leave until the judge approves that. And some of our adolescent staff are in the audience, and they know that that process is really difficult. And I wouldn't say frequently, but it happens on a consistent basis that the court will not follow our recommendation. So they've been here 5 to 7 days. We've done due diligence with assessment, putting a treatment plan in place, our recommendation to the court, and nope. So that's frustrating, yes. I think where that comes from, though, is they're frustrated. They don't know what to do with these folks. They have no answers, no options. And so the best one, get them off the street, get them out of the home and into a safe place until we can have time to explore resources, explore options. I think probably the court's at wit's end. I don't know what to do. So.
Sorry to keep asking questions here, but the governor vetoed some legislation recently about the mental health reorganization. But on the other hand, the governor did go ahead with a compromise to expand Medicaid. So with those extra people covered by Medicaid, what is your anticipation? Will it be easier to get some funding for these folks who need it, or is it going to be about the same issue of funding that we've had all along?
I think there will be an improvement. We will see more folks covered under Medicaid. Iowa Cares was a major issue for us, as it was everyone. But you know, Iowa Cares, initially when it came out, it was to cover mental health, but it was only to be at the University of Iowa or Broadlands. Well, then it just didn't cover mental health. It was excluded. So I know that now the mental health coverage will not be excluded, and we're going to see more folks covered under Medicaid. So I see it as a marginal improvement. So hopefully we'll have some more folks that'll be covered and can access services. Because really, the bottom line for some of these providers out there is they need some kind of payment in order to keep the doors open. And so hopefully we're going to be able to get folks some funding sources.
So, Christy, one of the things that's going to happen next year with the Medicaid expansion is there are going to be accountable care organizations that will be given the responsibility of keeping these Medicaid patients healthy and out of the hospital and hopefully out of mental health facilities as well. That's going to take a little bit of coaxing for a lot of physicians to take on some of these really mentally ill, chronically ill patients. But the whole purpose of an accountable care organization is to reduce the total cost of care. And so if you give some of these physicians and their staff, their teams, if you give them the responsibility of keeping them healthy and out of the hospital, something might actually improve, because that's obviously, as you say, one of the biggest issues here is the emergency department and the hospitals are cost centers, and we need to treat these people in less costly settings. So I hope that with these ACOs, that perhaps that will be a way to keep people healthier and keep them out of the hospital.
There's an excellent project, Dr. Kitchell, the Diamond Project, associated with the Mayo Clinic. And actually, I think that program has now gone throughout the entire state of Minnesota and is linking primary care with mental health providers to do exactly that, for getting ready for the accountable care movement. And phenomenal results. I have a lot of data and information on that. That's a project I'd love to see us start here in this community, related with working together with primary care and mental health providers. I don't know if everyone knows we have a new psychiatrist starting Monday here at the hospital, Dr. Casey Strozal, and she will be assuming the primary inpatient unit, and that means Dr. Trahan will be providing more services in his outpatient clinic. But with the availability of additional psychiatric support in this community, I think it would be an awesome opportunity to begin to look at that model of care, primary care, and perhaps utilizing him and doing something relative to the Diamond Project. So,
with the health homes, is that strictly voluntary on the patient's part?
I can speak to that a little bit. A lot of our folks that receive, I'll just go from my reference, but receive what we call habilitation services. So they're, chronically mentally ill adults. The way it's kind of working is that Magellan is sending letters to people to assign them to a health home. Their option is that they can choose to go into the health home, or they can choose not to. What they're going to get with the health home is kind of what you guys were just talking about. I mean, the idea is that you have the nurse, and you have the care coordinator, and you have the peer support specialist. They add a few layers, but they're all centrally, like I'll use Irely Ball for example. Here, they would have the nurse there, they would have the care coordinator there, that kind of thing. So there's a little bit more coordination, maybe, so to say. And they'll still be able to have their services if they choose, the way I understand it, if they choose not to opt into the health home. They just will not have someone coordinating those services for them. So.
I have a question, actually more of a comment. My name is Gregory Barclay, and I'm a psychiatrist and representing a group of 10 specialists providing mental health services here in Ames. And a couple of the comments I'd like to make. One about the concept of aligning mental health and medical systems has been shown repeatedly to be very useful. It's something we did about a dozen years ago through McFarland Clinic before the clinic shut down our mental health program, where we were putting psychologists side by side in primary care offices, and it was very well received. And another idea about putting mental health professionals in the schools, getting the professionals to where the patients are, has been also shown and repeatedly to be very useful. So it's good to see the movement occurring in that direction. I wanted to just, though, comment a bit on the private side of mental health services, which this presentation has been more focused on the community-based public mental health programs, which is a very enlightening presentation with some exciting developments occurring. And what Christy said, though, about funding is a critical thing, of course, in a private practice setting, too. As Jack Dodd, my colleague up there, used to say, you don't get paid much for talking with people, just doing things to them. And that's unfortunately true with the mental health system. Psychotherapy is the only procedure, one of the only procedures us psychiatrists can bill for, and it's very down. Some providers pay us about $60 for 45 to 50 minutes of that. And so it's really a very poorly reimbursed service. So the same financial problems and struggles go on in the private world with managed care than go with the public funding. That said, I did want to share with you all that in the write-up provided here, somehow the 10 providers that we have in the array of services we provide were somehow left off. We do provide a full range of mental health services to children and adults. Most of our therapists are trained in research evidence-based treatments, especially for depression. They all are trained in interpersonal psychotherapy and dialectical behavior therapy. We have a specialist in eye movement desensitization and reprocessing, which has been shown to be an effective trauma treatment. We have groups for anger management. We have an emotionally reactive adult group for adults who have trouble controlling their emotions. We have 2 substance abuse therapists. We have a substance abuse program. And so we do offer a lot of services that were not in this handout. And anticipating that, I did bring some brochures that describe our work. If anybody's interested, I'll be happy to give them to you after the presentation. So, thank you.
Any other questions for Erin or I? Well, thank you for your time today, and hopefully it's been helpful.